class. So I am going to do our week 7 endocrine and cerebral. I'm going to do a PowerPoint, but I'm also going to send you the Kahoots. Now, you know I do a Kahoots if I don't have a lecture first. It's very detailed and explained. I would go back, take your time, and it's less than an hour. Listen to the Kahoot, listen to the concepts and how I describe them. I think they're described where you'll understand DKA, you'll understand pituitary, adrenal, thyroid, parathyroid, and cerebral problems very easily by the way I describe it, all right? So I would let you know that. Next week on your syllabus is a quiz. No quiz, so you have your Thanksgiving week off. Remember next week though, the one thing is you have your pediatric assessment assignment due. People who are sending things to me, I'm looking at it, correcting it, and sending it back, okay? I don't expect perfection, but I expect you to put some time and thought in it. Many of you have chosen a subject that's near and dear to yourselves, whether you're a child or somebody you know, yourself, whoever. And I can really see these children through your eyes by the way that you describe it. So, take it as a learning experience. And that's what I really wanted this to be for you, a learning experience about something maybe you didn't know all about, or maybe it was just a revisiting and understanding. So I want to thank those that I've seen already. Some are pretty good. I'm learning myself, so thank you. So let's just go to the PowerPoint. Your final exam grades are going to be out about 2 o'clock on Saturday. They're there. Remember, this is week 7. Week 8 is your drop week. Nobody here is going to have to drop. You all are doing really great. And don't you dare drop on me. I'm teasing. You guys are doing good. Your homework is in. I don't have many complaints. I'll send a couple little reminders, but everybody's doing what they need to do. And that's what a nurse is. You do what you have to do to take care of your patients the best you can, take care of your class the best you can. So let's go ahead. Let's go to that PowerPoint. Week 7, it's got some really interesting things in it. I'm going to, of course, breeze over stuff that is just a reminder or whatever that you've seen it, whether it's anatomy or not. We don't go into all the lobes of the brain and what things do, and we don't do any of that, okay? What we do is if there's any injury, something that's going on to the brain. So increased intracranial pressure. The thing about it is the signs are extremely, very subtle. You'll see it first with a decreasing sense of loss of consciousness. This could be from a child hitting their head, falling down. I've seen them fall off of second-story balconies in apartment complexes. And, they come in and alert, and all of a sudden you can't wake them up. So number one, that you know that they're deteriorating is their level of consciousness, okay? We know there's all places where you can bleed in there. So those are all the names. I don't have you going into knowing or remembering, but there are different layers and different places where bleeds can occur. Signs and symptoms of an increased intracranial pressure in infants. Well, number one thing that you're going to hear is this very distinctive cry. It is very high pitched. You all know that I worked at Nicholas Children, and there's a big room with all the babies in it, and maybe there's 15 babies, 16 babies in a room. You could know which child was a child with neurological issues, increased intracranial pressure, hydrocephalus, all of that by their cry. And you go, oh, that's a neuro kid. What's going on with that kid? It's very distinctive. The best thing about infants is that fontanelle, that's out and it's puffy, it's bulging. Oh, that's easy, right? We have increased intracranial pressure. And do you see that big vein there? It's one of the cranial veins, and you'll see it bulge. Again, it's all that pressure pulling outwards. And then you'll get to the point where the eyes start doing crazy things as it keeps going. You'll see it start to try to open, and this kid's going to be irritable. Doesn't want to eat. Remember, kids, when they're not feeling well, they don't eat. Probably one of the number one things we see as older children. So, what are we going to see? We're going to see headaches. Let's talk about older children, not just infants. They've hit their head, they're increased intracranial pressure, they're bleeding in their brain. They're going to complain of a headache. Sometimes it can wake them up. It's so severe. Forceful vomiting, just not related to feeding. It's at another time. Sometimes it gets to the point of seizures, drowsy, lethargy, and then they don't know what you're talking about. You'll ask them to do something and they'll be like looking at you, staring. Again, that's lack of level of consciousness is decreasing. Something's going on there. Now, the late signs is bradycardia. You have a child who you know is having signs and symptoms of increased intracranial pressure, and all of a sudden their heart rate starts to drop. You better be in the trauma room because this child is going to crash and burn on you, as we call it. Okay. That is what you would see. Because initially it's your tachycardic, right? You don't know what to do. It's in pain. All of those signs and symptoms of pain you're going to be seeing. We're also now going to see that now they're not responding to commands. It's gotten to the point with such increased intracranial pressure that you'll take and just pinch the nipples to see if they even move because they are so in the late signs. Always those pupils. One of the first things medical personnel do when we know there's a fall and a concussion of some sort is we'll look at the pupils. What do they look like? Are they reacting or are they already dilated and fixed? Dilated and fixed, that is an absolute neurological emergency. They need to reduce that pressure in that brain, or it's going to squeeze some area of the brain and it's not going to come back to full functioning. Of course, that extension, flexion, the cerebral, the corticate, all of that's going to be start to see. And then it will go to the point of obtundation and a coma. And there it is there. From full consciousness, it's going to go down to now you're getting slurred speech, obtunded, and then you go way up to the coma. And that's just the levels as it go down. Now, the Glasgow Coma Scale is something done. It's used in the ER quite frequently. And what it does, it scores what a child is. And it's really helpful, especially when rescue does it. You've got a copter with a child in it. They say Glasgow Coma score of 6. You're like, oh goodness, I need to get help here. And then you make sure you get all the team. Or they'll say Glasgow Coma score 15. You know that child's awake, alert, and oriented, and that's going to be a less ill child as they first come in, but they can go downhill quick. We know that. And a 3 is they've got nothing. It's the worst score. They just get numbers because they have pupils, etc. Neurological exams is, of course, we're going to look at vital signs, skin, eyes are big, and then how are they moving? Their extremities, motor functionings, and then if you're starting to see these posturings that are going on. And children do the same sort of the cerebral, the corticate, tonic, clonic, all of those, as would be an adult. Picture from your book shows you all bunch of eyes, and the importance. Just remember that dilated one pupil, we know that the other side of the brain, there's swelling going there. So what do we do? Increase the cranial pressure. Number one, how do we, diagnose it? And then how do we treat it to keep this kid from getting to be a vegetable in the end? Because they could be. We're going to do lab tests. We always do electrolytes, very important, because fluid balance and not over fluiding the brain is a big thing. We don't want to put any more pressure there. An EEG can look at seizures, lumbar puncture. We can see what pressures in that cerebral spinal fluid. There's a way to put a manometer where that needle comes out of the back, okay? And there's like this glass tube, just like it was many years ago when I first became a nurse. And we could put the pressure and see where the pressure is. And we could see how severe it is. And it's one of those things that sometimes they do it just to look at the pressure, not looking for any signs of infection. X-rays, CTs, MRIs, all of these things are going to be done to look. Now, you've got a child and now they're unconscious for whatever reason, whether it's increased intracranial pressure or something else that's caused it. It is all children have all different outcomes. We don't know what it's going to be, but our job is to keep the airway open, keep that intracranial pressure as low as we can, and keep them out of shock. We're going to be checking the level of consciousness. We're going to look at the pupils and vital signs. When these kids come up from the ER into your intensive care units, you're going to be doing sometimes every 15 minutes, 30 minutes, 1 hour vital signs, pupils checks to see what's going on. And then it could go to probably every 2 hours. But, it depends on the severity of what happened, what's going on with that head. So we know if a child has a hypoxic episode, more than 4 minutes, somewhere in the brain didn't get oxygen, and there's going to be some sort of brain damage at that point. We know there's ways to increase and decrease intracranial pressure by just ventilating a child. So if we have CO2 retention, which means you're not breathing deep, and this is when you're intubated that you really can see this the most, and a comatose child most likely is intubated. So looking at the CO2, there's little machines just like A lines, arterial lines that we can look at, and we know if that number is going up, we know they're retaining CO2. And what that does, it dilates the vasculature and it puts more blood flow in the brain. And guess what? More pressure in the brain. So what do frequently? We will hyperventilate. We'll or take and just bag them or giving extra breaths on the ventilator to watch that CO2 come down. And we know then the pressure is going to be coming down, okay? We know we have to be worried about all the risks of aspiration and stuff, but remember, suctioning can cause problems. So we don't want to over suction. Now, we do ICP monitoring. We used to call it just the bolt, most common one that they put in. And it's just like an arterial line hooked up to the monitor, and we can watch the pressures and see what can affect it. And of course, if the pressure's going up, we're going to ventilate, right? Or maybe it's a positioning thing. So we know how to work with it with just those simple tools, ventilation. Very important thing to look at. And, a child who is unconscious due to a fall most likely is going to get some sort of intracranial pressure monitoring going on. There's different names, Richmond screws, sensors, sometimes catheters, but that one on the right, that's the bolt that I've been used to and I saw quite a bit. And, they numb it and put it in, but it doesn't hurt after it's there, believe it or not. So be careful. Make sure the airway's open. Make sure there's no pressure being restricted. I'll always take like a blanket and make a roll and have that neck extended so I know blood is flowing. And maybe I'll put even them next to their head to keep them from trying to, put their necks down, and it could cause, to compress one of those vessels. Elevating the head of the bed, make sure you check a doctor's order. Sometimes they don't want it over 30 degrees up. It has to do with the monitoring too. And again, what causes increased intracranial pressure? Well, suctioning, like I said, and then noise, the environment. ICUs tend to be very, very loud. These children, if there's a private room or one that we could close off, this would be that child that would take priority. Now, I've mentioned it already. There's a lot about intake output, over hydrating these children, and it's going to go to their brains and cause more pressure. So you have to be very careful. So strict intake output. We always, in any kid, even adults, we worry about nutrition. That's why almost immediately they're going to put some sort of feeding tube. They're using a lot of what we call ND tubes, nasal duodenal tube, and it goes past the stomach into the small intestines, and it prevents reflux. So it keeps it down there. And then we put it in, it floats down, we take an x-ray, we verify position, and then we give slow feedings to keep the tummy moving. And always, again, airway, keep it open, be concerned about secretions. So, question after I just said that stuff. When caring for an unconscious child, an appropriate nursing intervention is to what? I'll give you a second to read all that. A, B, C, or D?
I would say C.
Absolutely. It is intake output. Be careful, no fluid overload, because the brain's going to have fluid and is going to increase pressure. Okay, endocrine. Now, you need to be careful because there's different things in the endocrine system and you all get them jumble bumbled. There's pituitary, there is your thyroid, parathyroid, and your adrenals that we talk about a lot here. And of course, your pancreas. So try to keep them separated. And I know it's difficult, but figure out whatever works for you to keep it there. Pituitary's got two lobes. One works with intake output, that's your posterior pituitary gland, and you have one that works with growth, that has to do short and tall, dwarf or not. Okay, and that's the anterior lobe. So we know that depending on which area, the hypopituitarism and growth hormone, we know that that child is lacking it and it's going to be short. Now, why do you think every visit we do height and weight? Well, nutrition, right? But we're also making sure they're growing the way they should, because just because they're normal, et cetera, doesn't mean they might not have a deficiency of their growth hormone. So what you see with it is some children, they grow normal and then all of a sudden, they get overweight because they're short. Um, Sometimes we have tumors that cause either hypo or hyperpituitarism. Now, we give a growth hormone. Now, if a child is tiny and the parents want to take on that challenge, it's like having insulin because it's a subcutaneous injection every day, usually, sometimes 3 times a week, but let's say for sake that it's every day. So these children, until they get to the point where they're growing less than an inch a year, will be taking it every day to try to maximize how tall they're going to be. And the ages, it depends on the child, 14, 16, that's like a guesstimate, but until they stop growing. Hyperpituitarism is that big 8 foot tall person, right? We've seen them in the movies, et cetera, but they could be 8 feet tall. It doesn't mean all basketball players have a problem with their pituitary, but there are some people, because there's other facial things that you like, long faces, ears, jaws, et cetera, that could be part of it. Usually, and you can see here, I've got some pictures, older people, wasn't really much of younger kids to look at, but you could see the face is different. Usually it's due to a tumor. And you know how they remove a pituitary tumor? Up the nose, intranasally. So they don't have to open the head because it's in the middle of the brain. So they'll go up, they'll do x-rays, find out where it is, and they're going to be taking it out, usually surgical, radiation, and then they're going to need some replacement after surgery, depending on that child. All right. When you have, if you have a kid who's extra big, everybody's going to be saying something. So, as nurses, we're seeing a child, growing a lot. Look at the family. Are they as tall? Or are they short? So, if they're short people and they've got this really tall kid, something could be happening. So, catch it quick. Precocious puberty. I love the picture of the boy with the beard. I don't know if it's, photoshopped or whatever, but precocious puberty, the point is it's boys and girls. And usually they say under the ages of 6 or 7. That means girls getting breasts and boys getting hair where they shouldn't. And this is, due to this hormone. So um, children at ages 6 and 7 don't need to be teased. The little girl wearing a bra because she has breasts because nobody else has, and that's what kids do. And a boy having, a beard, that'd be something that these children would be teased about. We do Lupron, we do injections, we take care of it, and then we'll stop it when they're supposed to get into puberty about age 12. Okay, pituitary gland, other side. This is posterior pituitary gland. This has everything to do with fluid balance. Diabetes insipidus is 2 P's. You drink, 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 pee, pee, pee. And you're insatiable, drink, 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 pee, pee, pee. An infant, if you give them all of a sudden, they're drinking milk like crazy, 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 give them a bottle of water, all of a sudden they're not irritable anymore. The water keeps them happy. So diabetes insipidus is posterior tuber gland. Remember, it's hormones. It's just urinating. So what do you think we need to do for these children? Watch for. Well, intake, output, daily weights. We want to measure fluid balance and maybe some hormone replacement, as in vasopressin, DDAVP. I mentioned that about hemophilia too, right? So it also can be used in diabetes. How would you know vasopressin is working on a child who's urinating, drinking, drinking? They're gonna stop urinating and stop being thirsty. It's as simple as that, okay? Now, opposite of diabetes insipidus, where you're losing your urinating and drinking, is syndrome of an inappropriate anti-diuretic hormone against urinating hormone. So you're saving your urine, you're not urinating, and you fluid retention, and you feel absolutely horrible with it. Again, it's fluid balance, anything with fluid balance, intake, output, daily weights. Always, that's always going to be what you look at. Because you're retaining fluid, just like in the elderly, if they got edema and congestive failure, what do? Low sodium diet, water restriction. And of course, those daily weights, you're going to be looking at it. And they give what we call antagonists in order to try to overcome it. And it is for life. These two things are nothing that can be corrected. Now, thyroid. Thyroid is T3, T4, TSH, and they do measure your calcium with it, the calcitonin. That's more on the parathyroid. So I just say T3, T4, TSH. It could be too high or too little. The difference of thyroid disease, as in a hypothyroidism, is that, okay, in adults, you have cold intolerance, you'll have brittle hair, dry skin, in and constipation. In the child, they have all of that, but they need this for growth too. So that is the only difference between adult and children. It's also a growth thing that they need in order to grow to a proper height. So we can be born with it, and usually at birth, we're going to see a child who's not going to stool. It's one of the things that they check for. Cystic fibrosis is another one, and now we're looking, thyroid is another thing that looks for. So again, all those things that we see, and then again, we know it has to do with the growth is going to be less. But these are the signs: dry skin, sparse hair, those little puffy eyes, constipation, lethargy, mental decline, and there's going to have issues with their growth. Again, they give some sort of medication. It's compliance. And it should be in the morning, because if you ever heard a woman say, well, I'm a little overweight because I have a hypothyroid, because I don't work as quick. So you give the medicine, it sort of speeds you up. So you don't want to take it at night. It might keep you awake. So this is something that you should take in the morning. And again, how do we know the thyroid medicine's working? Monitoring height and weight. So easy, right? Goiter is something that happens in children, but not that much. Um, this is one that is children. Lymphocytic thyroiditis or Hashimoto. My daughter-in-law has it. Usually it's the teenagers, many of them are female, right as they become adolescents, and it's an autoimmune. You cannot remove it surgically. The only thing you could do for this is give the replacements of thyroid hormones as they need it. Again, you're going to see all of the big neck stuff that you see with it. But again, monitoring the levels and giving what they need for it. Hyperthyroidism, the other names is Graves' disease. All it is too much thyroid hormone is being produced. Too much thyroid hormone or taking medicine too much is going to have the hyperthyroid type symptoms, tachycardia, hyperthermia, chest pain. It is very scary, okay? It's either from the meds or from the body itself producing too much. Now, how do we treat it? Well, we give them medications first before we think of taking it out or ablate it. Now, one of the things about the medicines that we need to tell our patients is polythifracil and methimazole are for those to stop the body from overproducing thyroid hormone. But these causes leukopenia, decreased white cells, more susceptible to infection, so fevers and sore throats. That is a side effect. So we need to have these parents know that in case they get a sore throat fever, they need to tell their doctor. Sometimes they do this Lugol's thing where that also helps with hyperthyroidism. That was a HESI question a couple years back. The students were telling me about Lugol's and using it for hyperthyroidism. If the medicine's not working, you're still having these type of hyperthyroid type of crises. They could do a thyroidectomy or they can ablate it. This is what I just said, this crisis storm. The other name is called thyrotoxicosis. And again, this is the heart rate goes up, feels miserable. They give drugs, a beta blocker, propanolol, and it slows down the heartbeat when this is occurring in the ER. I had an x-ray tech one night when I was working night shift at South Miami Hospital, actually. And all of a sudden she felt bad and her heart rate was big. And she said, she had hyperthyroid. She came in with a heart rate of 260, brought her into the trauma room and had to give her Inderal IV, et cetera, et cetera. And it was sort of scary because it was somebody you worked so closely with, right? Hyperthyroidism, again, you need these children to understand that they're feeling that heart rate going up and stuff. They need to know. They're burning calories like crazy. So you could see increase the dietary requirements. They need it. And remember those drugs, the side effects, leukopenia. Now, parathyroid is not a thyroid. It is next to the thyroid. And what it does, it has everything to do with calcium. All right. Calcium levels are monitored there, and we need calcium. Whenever you hear calcium and magnesium, it's always to do with muscle contraction, whether it's the heart or any muscle in the body. Too much calcium, you're not going to be able to move because it's stiffened. It's so, calcified with calcium. And if it's low, you're going to also have, that weakness, etc. So remember that. That's a very important thing. Hypoparathyroidism, the dry, scaly skin. These are sometimes you see, but again, hypo is tetany, paresthesia, tingling. And then, of course, something with the respiratory, because again, what does calcium do? anything with muscles. It's going to be not enough. It's not going to work properly. We're going to be given some vitamin D, and that seems to help, and replacing that calcium whichever way. I mean, sometimes, believe it or not, it's as simple as taking a Tums every day, depending on the severity of these children. Remember, we always going to watch renal function with calcium, and we're always going to teach those parents about the possibility of seizures and the safety that has to do with that. Hyperparathyroidism is, again, it's too much, and we need to remove it. Many times we need to take that parathyroid out in order to keep those levels down. Very rare in children. Adrenal crisis. Adrenal crisis is an emergency because of no cortisol. And this is a lightheaded, dizzy, weak, sweating, nauseous, and it goes even to the point where they can become unconscious. This is usually due to an abrupt stopping of steroids. Why do you think a Medrol dose pack, when you've ever had it, goes from like 8 pills down to 1? They taper it for you. When you're just given a pill a day, it's harder to do it. But again, it is rare, but it does happen in children. It's very easy. So, in an adrenal crisis, because you've just stopped taking it, they're going to give you some, simply. Cushing syndrome. This is when you've had too much. Usually it is that prednisone that you're taking. For instance, rheumatoid arthritis. They treated it initially with 20 milligrams of prednisone a day. In the first year, I gained almost 80 pounds. And it wasn't because I eat. It's because the steroids puffed me up. Yes, once I tapered off and realized I don't need those things and realized what was happening, I slowly went off and, most of the weight came off until COVID, of course. But it does cause this puffiness. There's a bunch of things that you see with children. These are your symptoms of Cushing. Too much adrenal in there, which is the steroids. Excessive hair. I had hair on my chinny chin and my upper lip. Big round face and big red ruddy is the other word. Gaining weight was huge. Big belly. Poor wound healing was one of the things with it. Bruising. But these children have tiny arms and tiny legs. It's around the belly and around the face. So what do we do in case of this? Again, we're going to, if it's from the adrenal gland, surgery, but usually we talk about mostly when it has to do with steroids. Now, disorders of the adrenal glands. These are off of the kidneys, right? So we have the adrenal glands off the kidneys and they produce steroids normally. And part of those steroids are sex steroids. When you don't get enough sex steroids, children are born with ambiguous genitalia. You're seeing, it looks like a pronounced clitoris and testicle sac. Or it's I think even a vagina's in there. I've seen one in my career and it was different than normal. It's because they didn't get enough sex steroids. So these children, you must assign a sex to. After looking at the hormone levels, after looking at, ultrasounds, CAT scans, figuring out what we need to give. So it's a very scary time for parents. And as nurses, remember that. People are going to say, so did you have a boy or girl? Well, I don't know yet, right? And that is a very scary thing to have to say. So congenital adrenal hyperplasia, as I said, it's has to do with those congenital newborn stuff. And again, we're going to be giving them that reconstructive surgery, as I said, and these children will be on steroids for life. And they're going to be regulated according to stress, etc. Another thing about the adrenal gland, when sometimes tumors tend to grow on them. It's called a pheochromocytoma. It's an adrenal tumor, and it secretes epinephrine dopamine. These are catecholamines or sympathetic drugs. Heart rate up, blood pressure up, like nervous, chest pain, shortness of breath. And it's intermittent, very difficult to diagnose. Usually they look at the heart first, they look in the brain, see if there's a tumor, and then they say, all right, let's do a CAT scan. Let's look at those adrenals finally. And then they find it and they have to take it out. As a nurse, you need to be monitoring vital signs, heart rate and blood pressure, because it'll all go up. Okay, diabetes. Diabetes in children when they're young is always type 1. Usually you'll see type 2 as we get to adolescents that are overweight, okay? We know diabetes is you're hungry, you're thirsty, and you urinate. So it's the 3 Ps, polyphagia, polydipsia, polyuria. Remember, diabetes insipidus is only 2 Ps. This is a big common mistake that students forget. Which one is which, all right? DI is die, which means 2, right? And then diabetes type 1 is 3 with the hungry because they're not eating their sugar. The sugar's there, but it's not doing anything. So hypoglycemia, what do you see? Well, these children are really jittery, sweaty, dizzy. They don't feel good. So how would you treat somebody with a low blood sugar? Well, give them something sugar, glass of milk, glass of orange juice, and then follow it up with something protein, because the sugar will only work a little while and then the protein will help. So diabetes type 1 is all about the beta cells are being destructed in the pancreas. So now you're immunosuppressed. We know type 2 is later on in life, and sometimes they'll do it with the adolescents. So ketonuria, diabetic ketoacidosis, and what is going on? Well, diabetes is the body's not using sugar, and we have to give insulin in order for the sugar to be digested and to be able to be used by the body. When DKA happens because of ketoacidosis, for whatever reason, the body is not digesting carbohydrates, sugars. And the body says, I'm really hungry here. Hello, where is my insulin to help me eat? So it says, all right, well, I'm not waiting. Let me go to the fat and the proteins and start eating them up. The byproduct of that is ketones, which creates that acid metabolic acidosis. And we know a DKA will come in, it'll be beyond large ketones. It's an absolute emergency. These children come in, they're usually your adolescents that really aren't taking care of themselves or eating too much sugar or forget their insulin or one of those things. And they come in and they're pale and they are, barely holding their heads up. They usually come in a wheelchair. They feel so horrible. And you put them in their bed and these children are just sink in. First thing we do is start an IV and we give a fluid bolus. Why do we do that? Well, when we're doing the blood, we find out immediately you can do a Dex in 60 seconds. The blood sugar is off the scale. So we start an IV and we start that bolus of normal saline. It dilutes the ketones because we know they're going to be there, and it dilutes the sugar. So when we are with these children and we now have these DKA, they come in, they've gotten their sugar, their fluids. We've started a slow, regular insulin drip getting those blood sugars down. And now we're going to have to like continue to monitor them, because once you're diabetes type 1, you don't ever become 2. That's a misnomer. It doesn't happen. And some students think, well, when they get older, they'll be a type 2. Well, the pancreas don't work. The pancreas don't work. So we're going to be checking those urines periodically, and we have children even doing themselves. We do different numbers in children. We let them have blood sugars 126. In adults, it's 100, right? And random ones that we will do 200 or more is going to be okay. And when we look at hemoglobin A1Cs, actually they'll take up to 7. In adults at 6, you're pre-diabetic, and 6.5, you are then considered diabetes type 2. So there's a little different numbers. They give them a little bit more. We treat it the same. We give insulin, and we tell them how to do their blood glucoses. I've had kids come in 6 and 7 years old that do their own Dex when they're in there, using their machine. Well, actually, I have to use my machine because you have to have it documented. But they're going to do it themselves, and they really do an amazing job. Many of these children get on an insulin pump. And the great thing about that insulin pump is they put the needle into usually their abdomen, and you cover it up good, and it can stay there for a couple days. So it's one pinch. And if they're doing a blood glucose and they need a bolus, these children know how to program it to give themselves a bolus of insulin. So they're not getting stick with needles. And that's the best thing about this for children. So a nasal spray of desmopressin, DDAVP, is used to treat which ones? And it's more than one. We know it's diabetes insipidus and hemophilia from last week. So that was your PowerPoint for today. Actually, I did pretty good today with timing. So that's great for y'all. If you have not given me your diagnosis for your projects, please send it to me. Right now, we're pretty spread out with what we got. And again, try to get them in early so that I can check them and you guys can get the highest grades you can on them. And many of you I know living here, you're going to be going on for your BSNs because that's the Baptist way, right? So make sure I'm going to try to help you start to learn APA format and what to do. That's going to be starting you into your BSN programs, because that's the way it is here. I didn't have that. I went back to school by myself, and then they said, with all of these agencies and accreditations, oh, now you need everybody to go to school. Well, I was already done, so I was lucky. Any questions with anybody? Have a good evening, guys. I'll send you both recordings, the Kahoot and this one.
Thank you.
You're welcome.
Thank you.